Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Dr. Berte from Oslo, Norway. Dr. Bo is a consultant orthopedic surgeon and head of the arthroscopy section at the Oslo University Hospital with a special interest in complex knee and shoulder surgery. She defended her orthopedic PhD at the University of Oslo in 2012 and has been invited to several national and international meetings as speaker and faculty, both for knee and shoulder. She's the second vice president of ESSKA and has been the past president of the Norwegian Society for Shoulder and Elbow. Dr. Berte is also editorial member for AJSM, CASTA, the ESSKA Academy, and the Video Journal of Sports Medicine. She's a committee member of the ESSKA and also serves as Norway's national delegate to the European Shoulder and Elbow Society. She's been involved in the peer review process for arthroscopy and the Journal of ESSKA and is also a member of the AJSM Electronic Media Board. If you've noticed, Dr. Berte has delivered several lectures on our channel, and today's my great honor to bring back Dr. Berte for this wonderful live program. Over to you, Berte. Berte, can you hear me?
Yes, I can hear you.
Yeah, over to you.
Thank you for this introduction. And we agreed upon this topic about Bankart fractures this time, and I'm looking forward to have this presentation and afterwards conversation with you, because this is a problem that many orthopedic surgeons struggle with. So first of all, I have some disclosures. The Bankart fractures can be classified according to Edinburgh classification, which is the most used for scapular fractures. I will not say anything about other fractures, but this type 1, that is the Bankart fracture, is the most common glenoid fracture. And to divide them into different types 1, it's an easy dividement that 1A is less than 5 millimeter fragment and 1B is larger than 5 millimeter fragment. However, what helps us decide whether to do surgery or not and how much this affects the patients is not necessarily only the size of the fragment. And it's also shown that more than half of the patients having a shoulder dislocation actually have a bony fragment in the injury. Can be very small or can be a large one. So the problem often is when you see a fracture like that, is it just a small piece of bone, like less than 10% of the surface of the glenoid joint? So maybe the patient is better off with no surgery after the first dislocation. However, sometimes they are 20%, 25%, more than 30%, and it's obvious that you have to do surgery. So it's those patients in the gray zone there where we struggle. And also, it's not always so easy to get it in the right position. So that's also something to consider. So if the fragment is pretty much in place, maybe just put the arm in a sling and wait until it heals. What I have ended up with in my department, often discussing with colleagues what to do, is that we look at the CT scan, whether the head is articulated against the glenoid as the bigger part of the glenoid, or if it follows the fracture fragment, then it's subluxated and it's obvious that it has to be operated. However, the patient often lies on his back when the CT scan is taken. So maybe the head is subluxated when he is erect, compared to when he's lying on his back. It might go into the joint and look pretty well again. So one thing, at least, we have to take the patients to follow up very early to ask if they have experienced any more dislocations or subluxations after the first injury. So these pictures are from a 32-year-old man, young and active, and he had trauma in his left shoulder when he was skiing. And in the beginning, from colleagues or a nearby hospital, they were a little bit like, he's more than 30. The fragment is not that big. Maybe he will do better without surgery. However, when we took him back for follow-up, it turned out that he was feeling subluxations, and this was more than a week after. So for a young active man, feeling subluxation with this large fragment, we thought better off to do surgery on him immediately, and then most of the patients are stable afterwards. And of course, in these cases, you know that where you see the bony fragment, there's also the labrum. So the labrum is medialized in cases like this. It's been published several different techniques trying to use the new arthroscopic techniques we have learned over the last years, because doing fracture surgery of these Bankart fractures, even though they are more than 5 millimeters, doing it with screw fixation and open surgery might also be challenging. The direction of the screws, not always easy to get them parallel to the joint. And also the fragment is sometimes in more than one piece, and it might be difficult to get a screw in the fragment without cracking the fragment. So that's why we have been trying to do different arthroscopic techniques. And it's tempting to suture the labrum like we do in other Bankart procedures when it's not a bony part, because we know this technique very well. It's quite easy to perform arthroscopically. And for most cases, it's also acceptable reduction of the fragment. However, every surgeon that has tried to do this technique, either though they place one anchor at the top of the fragment, one anchor at the bottom, or they try to get around the bony fragment, know that it's not as easy as an ordinary Bankart. Sometimes the bony fragment flips when you tighten your sutures in the labrum. And sometimes it's very difficult to get around with some suture lasso or some other device to get a suture on the medial side of the fragment. And going either open or arthroscopically from here might be risky because of the neurovascular bundle that is passing in the area that we really want to go to get the right direction. So because it's sometimes difficult access, and to be sure that we don't get in the way of the neurovascular bundle, there is a tendency that when we do fixation of these fragments, they come a little bit lateral. And we all know what can happen if the fragment comes lateral to the joint line. Then the patient will probably have osteoarthritis faster than they would without this kind of fixation. So Boileau and Taverna has both argued to use the guide from posterior when you go into the glenoid, because then you can avoid the problem with the neurovascular bundle. And like in this picture, Pascal has demonstrated to us what might happen if you go parallel to the joint line and either go from anterior, or if you go from posterior and just continue, then you might get right into the axillary nerve. So this is, of course, what we have to avoid. And also, if we go to lateral to avoid the neurovascular bundle, then the fragment is often placed to lateral, and the patient will have osteoarthritis. So this is the challenge. Ettore Taverna published how he could use this guide from posterior, that is also published from Boileau for the Lattaché procedure. And it's also possible to use this to do the fixation of a Bankart fracture. And this drilling from posterior with a guide will be parallel to the joint surface, and then it will also be perpendicular to the fracture line in a bony Bankart. So this is actually a much better direction often that than you are able to get from front. So this is from the brochure of arthroscopic lattaché, and the guide is pretty much the same. There is also possible to use a guide with 2 holes. If you have a large piece of bone, you can of course get 2 tunnels in the fragment. However, at least in my cases, normally there's not room for more than 1. And if I were to use 2, I think I would have worried that the fragment was gonna break, because those fragments are often kind of thin and sometimes they easily break. So it's the same principle. And preoperative, I do this in lateral decubitus. You can for sure do it also in Beecher, but many of us are more used to lateral decubitus, and it's then easy to get the traction of the joint, so you have a little bit more space. Of course, keep the blood pressure low and preoperative antibiotics. So for these cases, you need the guide, of course. I also use a half pipe to get in and out, because the guide might feel a little bit bulky going into the joint. So instead of a cannula from posterior, I use this half pipe. And you need also the tensioner to tension the endobutton when you have managed to get it through both the glenoid and the Bankart fractures. So this is the video from one of the cases. Looking first from posterior, you can see the fragment there, and this is looking from anterior, anterosuperior. So for me, I very often switch from posterior view to anterosuperior to get this view, so you can look down in the fracture site and rinse it while you see into it. It's a little bit more difficult to see all of it from posterior. And you can also see the traction suture in the labrum. This is used to help me reduce, to see if I can get a fracture piece in place. I also secure the labrum with anchors below and over the fragment pipe, and the guide is coming in from, and you can use the guide to hold the fragment in place, and you kind of have to hold it there with the guide while you are drilling. So the sutures from the anchor I placed very low, and don't get confused by this, but this is actually from another patient, just to show you the details where I hold this fragment in place. So sometimes it's perfect anatomically. This one, you can see there's a millimeter step. We drill through the glenoid and the fragment, and this is the traction suture that you can put in the tunnel, because the tunnel is drilled with a sleeve. Here comes the button. And when you get the button anterior on the fragment and you tighten your sutures, you can see that you get your wanted compression. And those suture you see is from the distal anchor, and it's already taken through the labrum inferior. So I tighten this suture inferiorly in the end, and I also supply with an anchor on top of the bone piece after I have secured that it's in a good position. And you take these superior anchors and secure your labrum with that. So in the end, we use the NIS knot to tighten the endobutton. you need one button anterior and one posterior, and this knot is coming posterior. It's a sliding knot, quite easy. First, a sliding knot, and then at least 3 more knots to secure the fixation. And when you have done the sliding knot, we also use this tensioner. And if you first tension to approximately 50 Newton, you are still able to move it a little bit. You can check the position, see if you are happy with your reposition before you have to tighten it several times to between 75 and 100 Newtons before you then secure it with 3 more knots. So this is how the post-operative CT scan might look afterwards. And most of them have a good position. You have been looking into the joint. This one is maybe 1 millimeter medial still, but you have a very good tension of the button, keeping this in place, and also the suture anchors in the labrum. What we do after this operation is that we advise the patient to use a sling for protection in 3 to 4 weeks. However, if I trust my fixation, if something is normally I do that, and if it's not like that I'm afraid there's a fracture in the bone or something, I allow them to do very carefully passive movements from the first day after surgery. And I limit the movements in 4 weeks to 45 degrees of flexion and abduction and 20 degrees of rotation. From 4 weeks on, there's no limitation in movements, and they can start doing active exercises. And from 3 months, they can start doing strengthening exercises. And there's no restriction after 6 months. So this is how I do it now. And I have to say that I like the thought of doing the fixation perpendicular to the fragment, to the fracture line. And I'm very happy with this compared to just doing the fixation with a suture anchor or trying to do the fixation with a screw from anterior. And I feel it's safe, and I feel that the results are good for the patients. Thank you.
Thank you, Berte. Thank you, Berte, for this crisp presentation. Yeah, you can stop sharing. Thank you, Berte, for this crisp presentation and great surgical technique. I mean, it's a very complex one. You made it appear simple. I know it's very difficult.
Yeah, and that's why I kind of looked for some other way to do it. Because I had several cases. Sometimes we were 2 experienced consultants, and after being in a meeting where I saw somebody used some chondro darts, trying to do the fixation together with the anchors, I tried that for a while. But what really was frustrating for me was that I had the Bankart fracture in place, perfect in reposition. And when you tighten the sutures in the anchors, it flipped a little bit. It's something with the biomechanics. Then when you tighten the labrum, the bone piece has a tendency to flip. And I'm sure it's not only me that has experienced that, because it happens almost every time. So I felt that I really wanted some fixation going perpendicular on the fracture line. And this Endobutton makes it much more easy than everything else I have tried.
And Berte, some authors have described single point versus 2-point fixation, right?
Yes.
So what is your technique? Which group does it follow? Is it 2-point?
It is just one tunnel through the bony fragment. There is a guide where you can use 2 tunnels. So if it's a large piece of bone, of course you can use 2 tunnels. But I have to admit that even if I have it available, for all my fractures, I have only used one tunnel and tried to get it as central as possible in the fragment. And you get a really good fixation. So when I have tightened that endobutton, I feel that it's very stable, very solid. And then I know that in addition, I have the anchors around the labrum. So that's also an additional fixation. So the fixation through the bone is in one tunnel. So that's kind of 1-point fixation. And probably for most patients, that would have been sufficient. However, still, I do the fixation of the labrum as well.
Thank you, Berte. And Berte, I know that you're a very experienced shoulder surgeon. And are there situations where the fracture does not consolidate well and there is a risk for a redislocation?
You mean if the patient
If the fracture does not
come
unite well,
late, or if the fracture doesn't heal?
fracture doesn't heal and a tendency for redislocation. Is there a risk?
For these acute fractures, I cannot say that that has been a problem, that they doesn't heal. And I cannot remember last time one of the acute fractures that I have used this surgical technique. I cannot remember that they have not been stable. But of course, there are situations where maybe you didn't do surgery in the beginning. Maybe the bone piece was so small, so you said, "No, we'll just wait and see." Or in the beginning, before I started with this technique, sometimes we tried with screws or we tried with something else, and the bony fragment cracked in several pieces, and you just had to end up doing a soft tissue procedure. For those, I do the same evaluation as for all the instability patients, that if the bone loss is more than 10%, I also think of the other risk factors. And if I think there's a high risk for new dislocations, I go for a bony procedure. And for me, that is in most cases a l'attaché.
And Bertie, how early are you able to operate on an acute Bankart? For example, I'm sure we all see a lot of shoulder dislocations, right? So
yeah.
When do you get an MR? Because you need to get that acute fracture early, right? Only then your results are going to be great.
Yes, I'm in a situation in a big public hospital where the emergency unit is in 1st floor and my OR is in 4th floor. So I'm lucky to have most of these acute cases within a few days.
Okay.
But I have had referrals from other colleagues in other hospitals that has discussed with me whether we should try to do it like an acute fracture or not. And I remember especially one case that where he was more than 6 weeks down the line. I think it was 7 or 8 weeks. So I was a little bit skeptical and I thought, yeah, but it was a young man with a big fragment. And I could see the fragment lying like 1 centimeter medialized to the joint line. So I decided to try, and he's doing good. But of course, the fracture was almost healed, and you had to knock it to get it loose. And then I could use this technique also for him. But of course, a bony fragment that long after the injury might have been osteoporotic, might not have had the hole that I wanted, but I thought it was worth a try. So I guess at least up to 6 to 8 weeks, I would still try.
Thank you, Bertie, for that. And Bertie, we are also joined by Loy. Loy Al-Khatib is an orthopedic and sports surgeon based in Dubai. Loy, welcome to the show, and your questions to Bertie, please.
Hi, good evening, everyone. Thanks a lot for the nice technique, nice presentation. This case is really challenging, especially if you use your method of fixation. So you need to be in center of the fragment in order to get a good compression. Is that true?
Probably you don't have to be in the middle, but when I look from the anterior lateral portal and use the guide from posterior, you often need a traction suture or some kind of instrument from a second anterior portal. And then you try to be in the middle. And well, that's not more difficult than being inferior or superior. You just try to be where the bony fragment is at the broadest.
True, but in that way, you need a good distribution of the forces. So you need to have a good compression in that. This is the idea about that.
Yes, so you compress or you hold it in place with the guide.
Exactly. So this, I faced a lot of challenges, especially when I tried to fix the labrum after that. So I catch the original holes of the sutures and ending up cutting the sutures. So maybe one of the things that I have learned is drill all the holes together. So drill the holes from back to front and drill the holes for the labrum to fix it later on. So in that way you avoid catching the holes of the original sutures. Do you agree with that?
Yes, and Ettore Taverna, who published this technique first, I've spoken to him about it, and he says that he often drilled the tunnel with the pin and the sleeve around it and leave that in place and then place the anchors. However, I think it's easier to place the distal anchor first, and I'm not tying any knots. And I then place the guide and drill the tunnel and place the endobutton. And when I then place the superior anchor, I'm very well aware of that I don't want to ruin my endobutton suture. So I really think in what direction and what distance I place the superior anchor.
I agree. So last comment, do you believe these guys who fixed with this technique might have a faster recovery compared to guys who were fixed with the screws or other devices?
Screw is a very solid and good fixation. The problem with the screw is the direction. It's very hard often to get the right direction parallel to the joint. That's the problem with screws. It's a very solid, good fixation if you're able to get the right direction.
I agree. So there's no difference. This is the message here. There's no difference in recovery or recovery time, at least in the first 6 weeks, between the screws and Endobutton technique.
No, really not in the long run after a few weeks. My feeling, but I don't have data on that, my feeling is that for the first few days, this patient recovers even faster because it's arthroscopic procedure compared to open surgery.
I agree. Awesome.
Yeah.
Thanks again.
Thank you, Berte. I think, Berte, I think that's all the questions that we have for this session. And congratulations once again for being in the presidential line for ESSKA. Loy, I think his video is off. Loy, I think we should go to the upcoming ESSKA meetings that's going to happen in Prague, Czech Republic, where Berte is going to be first vice president, and in 2028 she's going to be the president. Congratulations.
Definitely. This would be our next visit.
We're going to go to Prague and then
yeah.
the 2028 meeting as well.
Sorry, I'm traveling to Madrid right now. Catch you later on, guys.
Thank you so much, Berte.
Perfect. Of course, I would like to welcome all of you to Prague. It's only 2 years.
You have a big following. Okay, so a lot of people are going to come.
Thank you so much.
Thank you so much. Bye-bye.
Bye-bye.